Headache syndromes. Headaches are one of the most common complaints of people seeking healthcare. Pain in the head is a symptom of underlying pathology. Most chronic headaches are tension, muscle contraction headaches, migraine headaches, or cluster headaches. Acute severe headaches may be a symptom of serious neurologic disease. Identifying the etiology of headaches requires an understanding of the characteristics of each type of headache. Pathophysiology and etiology. Tension, muscle contraction. Due to irritation of sensitive nerve endings in the head, jaw, and neck from prolonged muscle contraction in the face, head, and neck. Precipitating factors include fatigue, stress, poor posture, characterized by headband distribution. Second, migraine headache. Hyperactivity to the neurotransmitter serotonin, familial predisposition, consists of initial vasospasm, then dilation of intracranial and extracranial arteries. Migraine attack may consist of any 5 phases: prodrome, aura, headache, dissolution, and postdrome. Migraines are labeled with or without aura, usually visual. Aura is due to reduced cortical neuronal activity. Cluster headaches, usually unilateral, recurring, occur mostly in men. Release of increased histamine results in vasodilation. Other headaches, traction inflammation, due to infections such as meningitis, encephalitis, increased or decreased ICP lesions. Temporal arteritis, attributed to autoimmune disorder, inflammation of arterial wall may result in vision loss due to involvement of the ophthalmic nerve, usually occurs in persons over age 50. Sinus headache, results from inflammation of one or more of the paranasal sinuses. Clinical manifestations. First one, tension, muscle contraction, dull, band-like, constricting, persistent pain and pressure in the back of the head and neck, across forehead, bitemporal areas, may be tender points of head and neck. Second, migraine, sensory, motor or mood alterations precede headache. Gradual onset of severe unilateral throbbing headache may become bilateral. With classic migraine, characteristic aura may include scintillating scotoma, scintillating, scintillating scotoma, 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 scintillating scotoma, area of decreased vision surrounded by area of less abnormal or normal vision with zigzag appearance, that is scintillating scotoma. Hemianopia, loss of half of field of vision, and paresthesias usually last less than a day. Headache follows aura in less than an hour. With common migraine, nausea, vomiting, and photophobia may accompany headache, may last 4 to 72 hours and leave the person with limited food tolerance. May be triggered in women by hormonal fluctuations, especially in menses and pregnancy. Cluster headache. Pain is sudden, sharp, burning, excruciating, unilateral, always involving facial area from neck to temple, and often occurs during the evening or night. Occurs in clusters 2 to 8 weeks followed by headache-free periods. Associated with unilateral excessive tearing, redness of the eye, stuffiness of nostrils on affected side, facial swelling, flushing and sweating. Attacks last several minutes to several hours. Multiple attacks may occur in one day. Temporal arteritis. Unilateral or bilateral pain, particularly severe at night with tender temporal arteries. Last one, sinus headache. Pain is usually felt over sinus areas above eyes, along the side of the nose, and behind ears, or may be referred to points on the head. May or may not be accompanied by varying degrees of congestion, nasal drainage, post-nasal drip, and other symptoms. Diagnostic evaluation: skull sinus films to rule out lesions, sinusitis. Second one, CT MRI scan to rule out lesions, hemorrhage, chronic sinusitis. Third one, erythrocyte sedimentation rate ESR and other blood studies to help determine inflammatory process with temporal arteritis. Management, pharmacologic management. Medications are intended to reduce the frequency, severity, and duration of the headache. Effectiveness of medication is individualized. Some persons may need a combination of medications. Number 1, aspirin, acetaminophen, and non-steroidal anti-inflammatory drugs for mild to moderate pain of tension, sinus, or mild vascular headaches. Second, some drugs may abort vascular headaches if taken at the onset, including methysergide, Sunsert, a serotonin antagonist, ergotamine, and vasoconstrictor, or sumatriptan, a 5-HT agonist. Sumatriptan is available in subcutaneous injection as well as oral form. Other oral 5-HT agonists include zolmitriptan, naratriptan, and rizatriptan. ZOLMITRIPTAN, zolmitriptan. Naratriptan, NARATRIPTAN, naratriptan. Rizatriptan, RIZATRIPTAN, rizatriptan. Vasoconstrictors and 5-HT agonists used to abort vascular headaches are contraindicated in patients with uncontrolled hypertension, coronary artery disease, and peripheral vascular disease. Fifth point, inhalation of 100% oxygen may abort a cluster headache. Sixth, some drugs may be used continuously as prophylactic treatment for recurrent migraines, including beta blockers, calcium channel blockers, and tricyclic antidepressants. Seventh, antihistamines and decongestants may be effective for sinus headache. Eighth, corticosteroids may be used for temporal arteritis. Ninth, occasionally narcotic analgesics, muscle relaxants, and anti-anxiety agents may be needed for severe pain. Non-pharmacologic management. First one, relaxation techniques, guided imagery, paced breathing. Second point, biofeedback and cognitive therapy. Third, trigger identification and control of such factors such as intake of alcohol, red wine, skipped meals, over or undersleeping. Fourth, to prevent migraine, avoidance of monosodium glutamate, MSG, mixed spices with such as seasoned salt, nitrates and nitritis commonly contained in bacon, hot dogs, or deli meats. Fifth, rest in quiet, dark room at onset of headache. Sixth, if caffeine user, spread caffeine intake evenly over the day. Seventh, routine exercise program. Complications usually none. And nursing interventions must include controlling pain by reducing environmental stimuli, light, noise, movement, such as light massage to tight muscles in neck, scalp, back, and tension headaches. Applying warm, moist heat to areas of muscle tension. Encourage patient to lie down and attempt to sleep. And teach patient the cause of headache and proper use of medication. Second one, promoting positive coping, and third one, patient education and health management maintenance. Thank you.